Everyone, welcome to another day with your fertility specialist. I am Kadili Ojanugwa and I'll be your host for today. And here with me today is Dr. Deborah Olubeyim, our fertility specialist here at Alps Hospital. She's also a family doctor and has been in this business for a very long time with a lot of experience. Welcome, Dr. Debbie.
You very much to be here. Good afternoon, viewers.
Welcome, ma'am. To all our wonderful viewers, we always appreciate you for being here with us, for engaging, for your likes, for your comments, and for your shares. Also, today we'll need you to comment, like, and share this post, the link to every single person you think would need it, every single person you know would need it, and we really appreciate it. Thank you. On today's topic, we have a special topic that I'm sure has been in the minds of a lot of people. A lot of people do IVF, and sometimes, sadly, the results don't turn out to be what we imagined. The results are not very positive. So today we're going to talk about failed IVF cycles and what to do differently. So Dr. Debbie, the first question: when we say an IVF cycle has failed, what exactly does that mean?
Thank you very much. So when we say an IVF cycle failed, clinically, what that means is that you do a pregnancy test is negative. At least that's the first stage of failure, So and that's what we really largely used to say an IVF cycle pregnancy test is negative. We usually do pregnancy test between 10 to 15 days after an embryo transfer. So do a pregnancy test at that time. And when it's negative, that means that it didn't work, so it has failed.
Okay, how about for patients that come in earlier? Because I know some people, because of tension, they
Yes.
might feel they should come in earlier, or they might not be able to wait till the 10th or 15th day for the test. How about for patients that come in earlier and we find out their pregnancy test is negative?
That won't be conclusive. You won't take that as a failed pregnancy test because you want
Okay.
the hormone that the testing pregnancy test is human gonadotrophy, pregnancy hormone. And it has to reach a certain level in the body, in the system for the pregnancy, for a lot of our pregnancy tests strips to detect. That usually happens from about the 10th day after embryo transfer. For us to even remove any shadow of doubt about the result, we wait till between 12 to 14 days before we even do our. So we just calm them and allay their fears. They just need to wait to the right time for the appropriate time to test so that we're certain on what we
Thank you, ma'am. So the second question is, how common are failed IVF cycles even in well-managed cases?
cycles are quite common. When you talk about success rate of IVF, especially for the first IVF treatment, success rate for IVF will increase with the number of attempts the individual has had, the number of IVF treatment the individual has had. So for a first IVF treatment, field IVF is quite common. And like you said, in well managed cases, you can still have IVF. Unfortunately, yes.
Yes, that's really sad. That despite the fact that a lot of people put their hopes into a cycle,
Yes.
sometimes it can still turn out negative. So the third question is, what are the most frequent reasons IVF cycles fail?
Okay, so IVF can fail for a lot of reasons. One of the reasons are related to the embryos. Embryos are generated, an embryo is generated when the egg. So if you have poor quality eggs, which comes from a lot of issues, older age women that says they want to use their eggs in situations of polycystic syndrome, a client polycystic syndrome, sometimes egg quality is usually poor, you know. Also, when you have poor sperms, a man that has very poor sperms, then this will not lead to poor quality embryos being generated. So poor quality embryos, chances of pregnancy happening is lower. And even when pregnancy happens, chances of pregnancy progressing to the birth of a baby is also lower. So miscarriages can be common in that situation. Also, issues with the uterus. That's where the implantation happens. Can also lead to IVF failing. When you have issues such as fibroids, fibroids will alter the structure of the uterus, because fibroids. These are fibroids in the lining of the womb, endometrium, which is the actual part of the uterus where implantation happens. That affects implantation. It affects, changes the environment of the endometrium, and that prevents implantation from happening. Even fibroids in the body of the uterus intramural fibroids, depending on their size, of the womb can also impact on it because fibroids alter the structural environment of the uterus. They can even set up normal waves of contractions that can even push out the embryo, prevent it from implanting. Then also adenomyosis. So adenomyosis is also abnormality in the uterus failed IVF treatment. Adenomyosis, the hormonal environment of the uterus is altered, and the uterus even produces substances that impair or affect, prevent implantation. And this adenomyosis can also set up wave of contraction. It's a chronic inflammatory environment in the uterus that does not favor implantation. And then people that have abnormalities in the uterus, septic uterus, congenital abnormalities, all that will also impact on their implantation. Also, some people have underlying issues with thyroid abnormalities that does not allow implantation and pregnancy to progress. Even people that have poorly managed diabetes, other conditions, even that have polycystic ovary syndrome. Also have some hormonal imbalances that will not allow implantation, to happen. So you can see that any factors can lead to a fetal. Even people that take lots of alcohol, people that smoke, because people that this impacts even the garments themselves that generate the embryos that are going to be implanted. So all this, obesity, all that can impact implantation and lead to a failed IVF. So not the reason, it can. So sometimes it might just not be one. It can be multifactorial things contributing to the failed IVF in a particular point.
Okay. That's actually a lot of factors. And somebody
Yes.
who actually think them coming to the hospital for just once and get it out of time. Sometimes even factors out of our control and also factors with their lifestyle too can
Yes.
actually affect um so the sixth question here is how important is genetic testing like PGT in preventing repeated failures?
It's about embryo quality. So sometimes you have people that look normal, but they are chromosomal genetic testing, pre-implantation genetic testing. You are really decide those embryos that are chromosomally normal into the DNA, into the genes, right? So that's what move. So we can really notice embryos that are chromosomally normal. So that's what PGT does. Helps us to remove the abnormal embryos, which morphology, just looking at them. So it's important. So for people that have, have good quality embryos, supposed good quality embryos, looking at them and then repair failures are happening. You can really um, think any other thing that looks at doing PGT will be very of time. That will tell us the DNA makeup of the embryo.
Um, how about for older couples that use PGT if it's their
Definitely having abnormal embryos are with age, that's the reason why it's more difficult for a woman above the age of 35. By the time you're going towards the age of 40 to get pregnant, because the chances of having abnormal gametes are higher, chromosomally abnormal gametes are higher. This, and that's why you see things such as Down syndrome, are commoner in mothers that give birth at a more advanced age. So we would encourage, definitely for older couples, we encourage that if they must use their own garments, they should do it.
that's really insightful, Dr. Debbie. So the next question is how do you systematically evaluate patients after a IVF cycle? And what do you differently do the next
Yeah.
cycle?
So like I said, I said that chances of success is more with each cycle you have. Yes, success rate is higher. The more the number of cycles you have, because it gives you an opportunity to have studied, especially when this IVF you're doing done in the same place, because it gives you an opportunity to study the treatment. So when we have a field we usually go back to the drawing board to treatment. In our center, we have treatment sheets of each client's treatment and what was done at different stages. So we go back to the drawing board to look at the number of eggs or what were the qualities of these eggs, how was the stimulation protocol, what kind of treatment this person had, what kind of drugs was this person, the doses of the drugs. So each aspect of the treatment is evaluated. It was a learning build up. Like doesn't look optimal or what we feel there's something we can change. I know this is discussed with the client for us to now strategize on a way forward for subsequent treatments. So a lot of things are done differently. We can do different stimulation protocols. There
Okay.
are different stimulation protocols we can do. For example, clients that are older, we usually want to do short um, agonist stimulation protocols for them because that tends to give us more better quality eggs in in this group of clients. So that's one of the things we can do. We have different kind of drugs we can use. Looking at their AMH, thorough evaluation, we can decide to looking at their hormonal profile, different kinds of medication we use, and then we cancel on different things. If egg quality, or number of eggs issues, we can cancel this client. Maybe we should go with a donor egg. Next one, look at the endometrium. Even during our stimulation, we are always checking the endometrium, checking the lining, because there's an appearance of the lining, measurement of the lining that favors implantation. So if there are issues with the lining, we can ask for further testing to be done. A stereoscopy can be done because apart from uh, issues in the lining like adhesion, how one can implantation and then success. They are prone to fibroids in the lining. So a hysteroscopy, if this client has not had a hysteroscopy done prior to the IVF treatment, it will be a good sign. If the scan appears normal, it's still good to do a hysteroscopy so that you can, visualize the endometrium, the inner lining of so that any issues that scan is not really bringing up can be dealt with. Those are some of the things we can't say things depending on what we should advocate to this client. Why don't we try a surrogate to carry the pregnancy? So a lot of things are done to depend on what is found, depending on the client, whether improve the chance of achieving success in a subsequent cycle.
Thank you, Dr. Debbie. That is a lot of information and lots of knowledge. For our viewers, if you have any questions you would like to ask Dr. Debbie, you can drop them in the comment box below and we'll see that your questions are answered. Then, how do you individualize stimulation protocols for better outcomes?
Okay, so the individualization starts from a proper evaluation. So before clients get IVF treatment, they are properly evaluated. The medical history is gotten from them, they are physically examined, some lab work, or based on this lab test. We can now strategize and individualize the treatment. So I mentioned that people that are advanced in age or people that have a low AMH, which reflects talks about ovarian reserves. Those kind of clients we need to do a short protocol stimulation for them. People that even a client has had a long another protocol we call long agonist protocol that we that this client this time around do a short protocol
Protocol.
for you. Yes. And then depending on if you have hormonal issues such as polycystic ovary syndrome, the medications we use are also different. And some of these clients are placed on supplements, drugs to correct some of these hormonal abnormalities even before we go into the IVF stimulation. So all this helps to optimize and to better the outcome in a lot of clients.
So, how about for clients that have this?
Yes.
So you tackle that first before you
Then
go.
any medical issue be properly controlled. Hypertension, diabetes, if they have type issues, all that must be properly controlled. Even people that are overweight, obese, we want them to lose weight as much as they can. All that maximizes the treatment and helps to improve outcome with the IVF treatment.
So now to the emotional. So how do you counsel patients emotionally and mentally, especially after a IVF cycle, and how do you guide them?
So usually, even before the IVF treatment, we counsel patients. We offer a balanced counsel. Yes, we want them to be hopeful. We offer them all the support they need, but we want their expectations to be realistic. We let them know the issues we're seeing. We let them know the prognosis. What are the success rates, so that they have a balanced view, so that they manage their emotions appropriately. Yes, we want them to be hopeful. We want them to be optimistic about the treatment. But and then we let them know the IVF is not 100% success rate everywhere in the world. There's no 100% success rate for IVF. So we manage this expectation in the beginning. Then if a IVF treatment happens, we come to the drawing board. We offer as much support as we let them know that at the end, like I said, a lot of people must succeed on the first attempt. IVF success rate increases with the more we come back to the drawing board, look at the treatments, and then we offer way forward. We tell them, oh, let's do this. This is what we think we should do at this time. And then we encourage them, we give them a way to heal. We encourage them to get the support they need from their partners, families, you to heal appropriately before we attempt another trial. So we always keep in touch with our clients. We keep supporting them as much as we can through this journey of going through a failure. Like you said, it's not just not easy for the client. Yes, they bear the brunt of, but even us, the medical team, it's also our failure because most of these clients you've interacted because of them, and their journey is also your journey in a way. Spontaneous pregnancies.
Yes.
Yeah, so you want to evaluate this client properly. There are a lot of things you want to ask her. At what age of pregnancy has this miscarriages that she has had? At what age were they happening? You want to do a thorough workup, to see if, depending on her age is very important. Age is a very critical factor in that. So you want to take a thorough. So it's not to go for an IVF treatment to do you. This client needs to be thoroughly evaluated, try to find a cause for why it could be just be fibroids, it could just be submucous fibroids, and she has a fibroid surgery sorted. So we need to investigate further to know what is causing the miscarriages. If what is causing her to miscarry spontaneously is something related to the uterus, even if she has an IVF, those factors, she might still have a miscarriage. So the issues must be tackled. We must try to find out what's causing the miscarriages.
Okay. Thank you very much, Dr. Debbie, for your wonderful knowledge and insights. So you have answered a lot of very important questions regarding why IVF cycles fail, the factors around the
Mm.
failed IVF cycles like adenomyosis, endometriosis. You've mentioned even polyps in the uterus too. You've also mentioned how quality embryos, even when the embryos seem perfect on the
Good.
outside,
Yeah.
how their genetic makeup can actually be defaulted and how this can lead to recurring miscarriages. So thank you very much, Doctor, for all your knowledge, the information you have given us. They are really valuable. So is there any other thing you want to add? Anybody that might have done anyone meant to also.
Yes. So there's a lot to add. So if at the end of the world, yes, your doctors just need to go back to the drawing board. And I encourage them to the counseling doing. There are lots of things they can do. I talked about hysteroscopy. Sometimes you might even need to do further testing on the male garment, DNA, sperm DNA fragmentation index. You know, be open to the cancer doing, you're giving. Something different might need to be tried. So there's hope. There's a lot of things we can do. So let's not give up. It might be that you need to do PGT first before you have an embryo transfer. So there are lots of things we can do, and there's the chances of you going on to have a successful IVF are very high. So don't give up. So that's always my counsel. Don't give up. As long as you have life, there's hope. Don't give up. Open to the counsel you're giving. Open to trying the new things you're told. Open to the counsel. Don't close your heart, close your mind so there's always something to try.
Yes, so thank you, Dr. Debbie. As Dr. Debbie has rightly said, when there is life, there is hope. So don't give up. You might have had a failed IVF cycle, but that doesn't mean it's the end of the world. You can always go back and we'll always try. We are here with you for every single step of the journey. So we have come to the end of today's wonderful session. It's always a pleasure having you guys here with us every single time. So thank you very much, Dr. Debbie, for today's session. We'll see you guys same time, same place next week, Wednesday. If you have any questions, you can always drop them in the comment section. Or if you have any inquiries or would like to book an online consultation, you can that are going to be displayed below the screen for your online consultations. So see you guys next. Bye.